Birth stories are all unique, and sometimes they require a little support. These are called interventions, and we're going to spend some time talking about what some of the most commonly used interventions are. Dr. Amy is an OBGYN and a reproductive endocrinologist, and she will join us in just a few minutes to walk us through them. I want you to remember, this is your birth. Your provider is there to guide you and keep you safe, but ultimately this is your body. You have the right to information, and ultimately, you have the right to make the decisions. As we talk through these, consider taking notes on any interventions that concern you and talk to your provider about them. It might help you to feel empowered as your birth approaches.
Dr. Amy, it is so good to see you, and I'm so excited to pick your brain today.
I love talking to you. Thanks for having me.
Of course. So, I want to share just a couple of the interventions that are sort of most common in the birth setting, and I would love to hear just a little bit about why someone might have that intervention. Can you talk about IVs and IV therapy?
For sure. For example, if you're GBS positive, right? So that's not an uncommon thing. It's tested at the end of pregnancy. One of the ways we treat that is antibiotics, and the best form is through IV therapy. So if you don't already know your GBS status already and you're beyond 36 weeks of pregnancy, it's really important to ask your doctor what your GBS status is. And then also for your doctor to know what your antibiotic allergies are ahead of time so that they're prepared and they know what to give you once you go to the hospital. So that's one reason. The other reason is just like I mentioned in the first trimester, when you're feeling sick to your stomach, right? You're a little bit dehydrated maybe from contracting at home, and maybe they even have a planned C-section for you and they don't want you to eat or drink, so they're going to hydrate you with that IV fluid. And then the other thing is, a lot of times these centers, they recommend active management of labor. And if that's something that you're agreeable to, Pitocin is an IV medication that they'll put through your IV, and that's how they do it. They actually, they basically take the Pitocin medication and they put it into a bag of IV fluid, and then it'll go through your veins that way.
So, can you talk a little bit about the monitoring options that are available in labor? We usually talk about continuous monitoring and intermittent monitoring.
Absolutely. So, I think knowing what your labor plan is going to be before you go to the hospital and being educated about that and taking classes like people are doing right now, reading the motherly book and then talking to your doctor as well as far as what they recommend for you. I think that's a really important thing to do before you get to the hospital, because there are some people that would actually prefer intermittent monitoring, because they want to try and have every birth is natural as far as I'm concerned, whether it's a C-section or vaginal delivery, right? But some people would prefer intermittent monitoring. So that's basically listen to the heartbeat at certain intervals while you're at the hospital. And then when you're closer to, getting the pushing phase, that's usually when we'll listen a little bit more often. It's hard to find a physician out there that has a lot of experience with a forceps delivery. And that's just a way of, going in and basically scooping the baby out if there's any type of distress or it looks like the baby's not coming out the way that the doctor wants the baby to come out. Some doctors would opt to do a C-section instead of a forceps delivery. And then a vacuum, there's certain rules and criteria, and I'd like to think everyone follows all the right set, the right set of criteria and rules as to which babies fit the criteria for a vacuum delivery. And that's basically where we place the suction cup on the baby's head. And then with the mom pushing, then we can actually, bring the baby out. And so, you, again, be educated about what these different things are before you even go in. And then you have the right to decline these interventions. You certainly do, and to opt for a C-section. But having a lot of trust in your doctor, I think, is really important. What do you think about that, Dana?
Yeah, absolutely. No, I agree with you. So, normally we say the word operative delivery and it sounds like an operation when we think surgery. really an operative delivery is, I always describe it as assistance, getting the baby out a little bit faster, but still having that vaginal birth. Often these will be used in, sort of situations where maybe baby is showing some signs of distress, and we need to get baby out quickly, but we're so close to having that vaginal birth. So we just, grab the vacuum and assist. And they're rare, they're not super common. And I think you're totally right, having lots of conversations with your providers, if you're nervous about it, saying, if this, then what? So under which circumstances would you suggest that I have a vacuum, assisted birth? Questions like that can help you to feel a lot more, like you said, informed, aware, and therefore empowered, and therefore less scared as you approach your birth. Can you tell us, first of all, what is an induction?
An induction is where, the team, I'll say one of the team members, whether it's your midwife or your doctor, feels like there is a medical indication for the baby to be delivered. It could be because, let's say, you're over your due date, or you're not over your due date, but they're seeing something like, the baby is maybe a little bit large, and that term that we use is called macrosomia. Or maybe there's too much fluid around the baby. So that's a term called polyhydramnios. Usually there's a medical indication where your doctor thinks that it would be safer for you to have the baby and have the birth date be sooner than later.
Yeah. What happens if someone comes in for a medical induction? So they're going to come in and maybe they're going to get Cytotec and then Pitocin, for example. Can you share a little bit about those medicines and what that process will be like?
For sure. So once you go in, you'll get evaluated. The baby will be placed on the monitor, and they'll assess the baby for basically that the baby looks good, right? And they'll be like, thumbs up, we can move forward. And they'll again have a checklist to say, baby meets all these criteria for us, and also your blood pressure, all of those things, for us to be able to move forward with this medication. Cytotec is placed vaginally. And this medication, once placed, it's kind of hard to get it out of there.
Yeah.
And one of the risks are, you can have a lot of contractions really fast. But it's actually pretty well tolerated, and it's been around for a really, really long time. And then with Pitocin, the cool thing is you can turn it off, right? So if you start contracting a ton, they can turn the IV fluids off, and they'll watch you very closely. And then once you're on Pitocin, you can't go home on it. There's no pump that you'll walk home with that has Pitocin running in it. So
yeah. Yeah, that one would be less fun to experience at home for sure. And Foley bulbs, another method of induction. Can you talk a little bit about Foley bulbs?
Yeah, a Foley bulb is basically a tube with a balloon on the end that gets inflated and then placed inside the vagina through the cervix. And it basically causes an anatomic stretching of the cervix, right? So you're just pushing a bulb through to kind of stretch it out so that can induce or bring on contractions and bring on labor. So that's something that's been around also for a really long time. There are risks with all of them. With the Foley bulb, there might be a higher risk of an infection, for example. But I think the biggest risk for people to realize is that sometimes they don't work, no matter how many things you try. So you got to you're in it until you win it. And then sometimes when one thing doesn't work, your doctor will go to another, and then sometimes you have to end up with a C-section, and that's okay.
Yeah, I love that you mentioned that, because I think that, again, it goes back to just having a really open communication with your provider, and asking lots of if this then this type questions, and also saying hey, can you keep me super apprised about what you're thinking and up to date, and if you are starting to think about C-section, I want to know sooner rather than later, so that you can again feel as sort of educated and empowered as you move through the process.
Simple questions. What are you doing?
Yeah.
Why are you doing it? And how is it going to make me feel? That's it.
Yes.
And then you can also ask them, what are the risks of what you're doing? So it's those are simple sentences that you can use. So you're empowering yourself with the knowledge that you need to have. So you feel like you're in control and not in a situation where people are doing things and you don't understand why they're doing them.
Absolutely. And then one more is artificial rupture of membranes. Normally, in my experience, we do this to help move labor along if a labor has sort of stalled. Anything you want to add about artificial rupture of membranes? This is for those that don't know, it's just breaking somebody's water usually while they're in labor. And because the membranes don't have nerves, it usually doesn't hurt other than the experience of having a vaginal exam.
Yeah, I mean, some people have a style where they like to do it after the epidural or before the epidural, so you're not experiencing painful contractions afterwards. That's just something to be aware of. And
Mhm.
I think most laborists will talk to their patients about
Yeah.
that, so that you're not experiencing painful contractions when you may not want to have that experience.
Yeah.
So yeah, you're right. I mean, just something that we do to bring on more frequent contractions to have a baby deliver sooner.
Yeah, absolutely.
So yeah, I mean, I think the recovery can be harder depending on what happens, once you start. But even if you have a really easy induction, if it takes, let's say, 1.5 days, you're in a hospital for that long, away from your home.
Yeah.
It's tiring. You're not able to sleep really well. So I do think that sometimes you have a harder recovery when you're induced, just because of those little discomforts, maybe from being away from home, not sleeping very well, being bothered nonstop with these checks that have to happen.
So we're so annoying. We are
Yeah.
so annoying in the
Yeah. So
hospital.
bring your boat, bring your headset, bring
Yes,
your,
bring
your
your
mask over
thing.
your
Yeah.
head. Totally. Bring your fuzzy socks.
But I love preparing people for this, because then if you have an induction or a cesarean birth, maybe you can see if you can spend a little time ahead of time sort of recruiting your village. Hey, listen, I'm going to have an induction. I think I might be even more tired. I'm going to need extra lasagnas in my fridge, please. Or I'm going to need extra help taking care of my toddler, or whatever it is, so that you can sort of set yourself up to be well nurtured after an experience like this.
Yeah. You have to know how to ask for help. And sometimes people don't realize that until after they have the baby. And it's so important to
Yeah.
find help you need at the very beginning.
It's so true. It's so true. Well, thank you so much for talking to us about interventions and inductions. It's lovely to see you as always.
Oh, thank you, Diana.